Welcome to Lecture Boss. My name is Dr. David Avarbock, and today we will discuss the pediatric tumors you must know for steps 1, 2, and 3, and the shelf exams. This is the second of two lectures on this topic. In the first lecture, we covered tumors of the CNS, eye, skin, blood, heart, endocrine system, and kidney. In this lecture, we will cover tumors of the GI system, bone and soft tissue, ovaries and testes, and extragonadal germ cell tumors. Let's discuss tumors of the gastrointestinal system. What is the most common overall malignant GI tumor in pediatrics?
Non-Hodgkin's lymphoma. The most common subtype is the sporadic form of Burkitt lymphoma, usually found in the ileum.
Correct. The rare small intestine tumors in children include adenocarcinoma, the most common type in adults, GI stromal tumors, and carcinoid tumors. What are the syndromes associated with an increased risk of colon cancer in pediatrics?
There are four autosomal dominant polyposis syndromes that increase the risk of developing colon cancer. Each one results from a mutation in a tumor suppressor gene. These include familial adenomatous polyposis syndrome, or FAP, Lynch syndrome, Peutz-Jeghers syndrome, and juvenile polyposis syndrome.
Very good. Patients more commonly develop colon cancer as adults, but they can develop it at a younger age, so early surveillance is necessary. Describe the molecular characteristics of a tumor in FAP.
To develop a malignant tumor from a polyp, there's a sequence of molecular changes from adenoma to carcinoma. First, the patient inherits a mutated APC tumor suppressor gene. This gene is responsible for regulating cell growth and adhesion in the colon and chromosomal stability. Loss of APC is followed by mutations in the KRAS proto-oncogene and then mutations in either the P53 or DCC tumor suppressor genes.
That's correct. What are the diagnostic tests for familial adenomatous polyposis syndrome?
Colonoscopy with biopsy will show polyps with tubular or villous morphology. Villous adenomas have a higher malignant potential.
Correct. The tumors in FAP are commonly found in the left colon. We discussed in the first lecture that FAP has two variants: Gardner syndrome, involving bone and soft tissue tumors, and Turcot syndrome, involving brain tumors. Let's discuss Lynch syndrome. Describe the molecular characteristics of these tumors.
The tumor has mutations and silencing of MLH or MSH genes, which code for DNA mismatch repair proteins. This leads to microsatellite instability and an adenoma to carcinoma sequence.
Good. What other cancers are patients with Lynch syndrome at risk for?
In addition to colon cancer, patients with Lynch syndrome are at risk for endometrial, ovarian, and gastric adenocarcinomas, as well as melanoma.
That's correct. The tumors in Lynch syndrome are commonly found in the right colon. Peutz-Jeghers syndrome involves a mutation in the STK tumor suppressor gene, which regulates cell growth, metabolism, and apoptosis. What are the clinical characteristics of this syndrome?
Patients with Peutz-Jeghers develop hamartomatous polyps in the GI tract. These polyps have a low malignant potential, but they put the patient at risk for obstruction and intussusception. Patients also have hyperpigmented macules on the lips, hands, and genitals that appear by age 5.
Very good. While the hamartomatous polyps have low malignant potential, the loss of the tumor suppressor puts patients at risk for many cancers. In addition to colon cancer, what other cancers are patients at risk for?
They're at risk for gastric, pancreatic, breast, and ovarian adenocarcinoma.
Correct. Juvenile polyposis syndrome involves the formation of juvenile polyps, which are hamartomatous polyps in the GI tract. While juvenile polyps are benign, there is a risk of malignant transformation when patients have the tumor suppressor mutations associated with juvenile polyposis syndrome, leading to colon and stomach cancer. What is the most common liver tumor in children, and what syndrome is it associated with?
The most common liver tumor is a hepatoblastoma. It is also associated with Beckwith-Wiedemann syndrome.
Correct. We discussed in the first lecture that a nephroblastoma, or Wilms tumor, is also associated with Beckwith-Wiedemann syndrome. Patients may have macrosomia, an enlargement of half their body, an enlarged tongue, hypoglycemia, umbilical ring hernias, and omphalocele. These patients have mutations in the WT2 tumor suppressor. Pancreas tumors are rare in children. In the first lecture, we discussed pancreatic islet cell tumors when we covered endocrine tumors. Pancreatic islet cell tumors are associated with MEN1 and von Hippel-Lindau disease. Earlier, we mentioned that Peutz-Jeghers syndrome was a risk factor for pancreatic adenocarcinoma. Stomach tumors are also rare in children and are mostly benign tumors, such as leiomyomas and benign teratomas. As mentioned earlier, there is an increased risk of gastric adenocarcinoma in Lynch syndrome, Peutz-Jeghers syndrome, and juvenile polyposis syndrome. Cancers of the biliary system are also extremely rare. The most common tumor is a biliary rhabdomyosarcoma. Cholangiocarcinoma can occur in children who have biliary cysts and chronic inflammation. Let's discuss sarcomas, tumors of connective tissue. These include sarcomas of bone and soft tissue. Name 2 primary malignant tumors of bone and the epidemiology of these tumors.
Osteosarcoma and Ewing sarcoma. Osteosarcoma is the most common primary malignant bone tumor and most commonly occurs in adolescents, 10 to 18 years old, during the growth spurt when there is more cell division. It is slightly more common in boys than girls, and a bit more common in African Americans than Caucasians. Ewing sarcoma also occurs during adolescence and is more common during the growth spurt. It is slightly more common in boys than girls and is much more common in Caucasians than African Americans.
Very good. What are the characteristics of the tumor in osteosarcoma?
Osteosarcoma arises from mesenchymal cells, which become osteoblasts in the inner layer of the periosteum.
Correct. What are the genetic disorders associated with an increased risk of osteosarcoma?
The first is Li-Fraumeni syndrome, caused by an inherited p53 mutations, which also confers an increased risk of medulloblastoma in children and breast cancer in adults. The second is mutations in the retinoblastoma gene, which also increase the risk of developing a malignant tumor of retinal cells.
Good. What are the clinical features of an osteosarcoma?
The tumor most commonly develops in the metaphysis of long bones, such as the distal femur and proximal tibia. The patient may first complain of pain, often in the knee, which gets worse with activity or at night. There may be swelling, redness, tenderness to palpation, and decreased range of motion. The patient may have fever and weight loss. Osteosarcoma may also present as a pathological fracture. If the tumor metastasizes, it most commonly spreads to the lungs.
That's correct. What are the diagnostic tests for an osteosarcoma?
The initial test is an X-ray where you will see a periosteal reaction, which is the growth of new bone. You may see the sunburst appearance and Codman's triangle. Bone biopsy will show malignant osteoblast cells and woven bone. Labs will show elevated alkaline phosphatase and LDH.
Very good. How do you treat osteosarcoma?
You perform surgery to remove the malignant mass. Sometimes amputation is necessary. Chemotherapy is also used, and the most common regimen combines methotrexate, doxorubicin, and cisplatin. The tumor does not respond well to radiation.
Correct. The most common benign bone tumor and most common bone neoplasm overall is an osteochondroma. What are the characteristics of this tumor and its clinical features?
An osteochondroma is also found at the metaphysis of long bones. It is a tumor of chondrocytes and is usually asymptomatic. However, these are bony outgrowths with a cartilage cap, and occasionally they can be painful, but very rarely cause pathological fractures or transform into chondrosarcomas.
Good. What are characteristics of the tumor in Ewing sarcoma?
The tumor derives from neuroectoderm cells and usually involves an 1122 translocation that creates a fusion protein. It is a very aggressive tumor and it metastasizes early, most commonly to the lungs.
That's correct. What are the clinical features of Ewing sarcoma?
The tumor most commonly develops in the diaphysis of long bones, usually the femur or tibia. It can also occur in the humerus or pelvic bones. The clinical features are similar to osteosarcoma.
Very good. What are the diagnostic tests for Ewing sarcoma?
The initial test is an X-ray, and it will show a periosteal reaction that gives the bone an onion skin appearance. You will also see lytic bone lesions. Bone biopsy will show small blue round cells that resemble lymphocytes. Tumor cells will have the 1122 translocation.
That's correct. What is the treatment for Ewing sarcoma?
Surgery and chemotherapy. The chemotherapy regimen alternates between two sets of drugs, vincristine, doxorubicin, cyclophosphamide, and ifosfamide, etoposide. Radiation therapy can also be performed if surgery and chemotherapy are ineffective.
Very good. Multiple myeloma is a tumor of plasma cells that originates in bone. It does occur in the pediatric population, but it is very rare. Let's discuss one more benign bone tumor, the osteoid osteoma. What are features of this tumor?
Osteoid osteomas are derived from osteoblasts, and they are small, less than 1.5 centimeters, and they do not enlarge. They produce osteoid, unmineralized bone. The tumor also produces prostaglandins, which cause pain.
That's correct. What are the clinical features of an osteoid osteoma?
The tumor is more common in males, teenagers, and young adults. Clinical features are pain in the long bones, most commonly the femur and tibia, with pain around the knee, and the pain is often worse at night. The pain of an osteoid osteoma can be relieved with NSAIDs, which can distinguish it from an osteoblastoma, which can look similar histologically.
Very good. An osteoblastoma will be larger, greater than 2 centimeters, and it will occur more commonly in the vertebrae. Langerhans cell histiocytosis, LCH, is an overproliferation of Langerhans cells, a type of dendritic cell made in the bone marrow. What age group does LCH occur in, and where is this tumor most commonly found?
Langerhans cell histiocytosis appears in children from 5 to 10 years of age. It is most commonly found in the bones, usually the skull. LCH can also be found in the skin, where Langerhans cells usually reside, and cause brown or purple papules.
That's correct. What are some molecular features of this tumor?
The tumors are S100 and C1a positive and contain Burbeck granules, tennis racket or rod-shaped inclusions. A high percentage of tumors have BRAF mutations.
Correct. Treatment is with surgical excision if the patient is symptomatic, and steroids and chemotherapy if multiple organs are affected. Targeted therapy with BRAF inhibitors is also attempted in certain cases. Let's discuss soft tissue sarcomas. These tumors originate in tissues such as muscle, nerve, fat, or blood vessels. Certain genetic diseases increase the risk, such as Li-Fraumeni, neurofibromatosis 1, or tuberous sclerosis. Symptoms vary depending on the type of sarcoma, but the tumor often starts as a painless lump under the skin and becomes symptomatic as it grows and compresses organs and nerves. What is the most common pediatric soft tissue sarcoma in children under 14 years?
This is a rhabdomyosarcoma, a tumor of rhabdomyoblasts, primitive skeletal muscle cells.
Correct. What are the clinical features of a rhabdomyosarcoma?
The tumor most commonly occurs in children under 10 years and usually grows in the orbit of the eye, but can also be found in the head and neck or extremities. It can cause swelling and pain and make the eye bulge out or cause gaze abnormalities. It may compress nerves and cause gait disturbances.
Very good. Treatment is with surgical resection and possibly neoadjuvant and adjuvant chemotherapy and radiation. Rhabdomyosarcomas most frequently metastasize to the lungs. What is the most common soft tissue sarcoma in children over 14 years?
A synovial sarcoma. Synovial sarcomas arise from the primitive mesenchymal cells, not actually from synovial cells. These cells are precursors to different connective tissues such as bone, cartilage, muscle, fat, and blood vessels.
Correct. What are the clinical features of a synovial sarcoma?
The tumor is found around joints in the arms, legs, and feet. It may initially present as a painless lump that becomes more painful as it grows.
Good. Treatment is with surgical resection and possibly neoadjuvant and adjuvant chemotherapy and radiation. Synovial sarcomas most frequently metastasize to the lungs. Let's discuss ovarian tumors. What are the most common classes of ovarian tumors?
Ovarian tumors can be divided into epithelial tumors, germ cell tumors, and sex cord stromal tumors.
Correct. What is the most common class of ovarian tumors in pediatrics?
Germ cell tumors are most common. Epithelial cell tumors are most common class in adults, but are less frequent in pediatrics and usually occur in older children. Sex cord stromal tumors are the least common.
Very good. Name the germ cell tumors that occur in pediatrics.
The most common overall ovarian germ cell tumor is a mature cystic teratoma, also called a dermoid cyst. It is a benign tumor. An immature teratoma can be malignant. The most common malignant germ cell tumor in adolescents and young women is a dysgerminoma. The most common malignant germ cell tumor in children under 5 years is an endodermal sinus tumor, also known as a yolk sac tumor.
That's correct. What are the tumor characteristics and clinical features of a mature cystic teratoma, the most common overall germ cell tumor?
These benign tumors contain tissue from all three germ cell layers, such as bone, hair, or teeth. They have very low malignant potential, and there are no associated tumor markers. They are usually asymptomatic, but a large tumor could cause abdominal pain or compressive effects on the bladder.
Very good. There is a mature teratoma that contains only one germ cell layer. What is this tumor called, and what are the clinical features?
The struma ovary only contains endoderm, which differentiates into thyroid tissue. It will secrete thyroid hormone and in a minority of cases will cause hyperthyroidism.
Correct. What are the tumor characteristics and clinical features of a dysgerminoma, the most common malignant germ cell tumor in adolescents and young women?
These malignant tumors have rapid growth and cause pelvic pain and a pelvic mass. They are the female equivalent of a testicular seminoma and have a fried egg appearance on histology, with a central round nucleus surrounded by clear cytoplasm. The tumor marker is LDH.
Good. What is the treatment of a dysgerminoma?
Surgical removal. Fertility-sparing options may be adequate in early stage disease. Later stage disease may require chemotherapy. Most regimens will involve a platinum agent, such as the bleomycin, etoposide, cisplatin regimen.
That's correct. These tumors are very responsive to chemotherapy and have high cure rates. What are the tumor characteristics and clinical features of a yolk sac tumor, the most common malignant germ cell tumor in children under 5?
These tumors have rapid growth and cause pelvic pain and a pelvic mass. On gross exam, they appear yellow. On histology, you see Schiller-Duval bodies, which resemble glomeruli. The tumor marker is alpha-fetoprotein.
Very good. What is the treatment of a yolk sac tumor?
Similar to a dysgerminoma, the treatment is surgical removal. Fertility-sparing options may be adequate in early stage disease. Later stage disease may require chemotherapy. With early treatment, yolk sac tumors have a good prognosis.
That's correct. What is the most common ovarian epithelial tumor?
The most common epithelial tumor is the benign serous cystadenoma. The most common malignant epithelial tumor is the serous cystadenocarcinoma.
Good. What are the clinical and molecular characteristics of the malignant serous cystadenocarcinoma?
These tumors present with abdominal or pelvic pain, bloating, and urinary frequency. If the tumor metastasizes to the peritoneum, the patient will have abdominal distension from ascites. Histology will show psammoma bodies. The tumor marker is CA-125.
That's correct. Name the sex cord stromal tumors that occur in pediatrics and their clinical and molecular characteristics.
The most common sex cord stromal tumor is the juvenile granulosa cell tumor. These tumors can secrete estrogen and can cause precocious puberty. Histology will show Call-Exner bodies, and the tumor marker is inhibin. Sertoli Leydig cell tumors are less common. They can secrete androgens and can cause virilization effects and also precocious puberty. Histology shows Ranke crystals. There is no associated tumor marker.
Very good. Let's discuss testicular tumors. What are some disorders associated with an increased risk of testicular tumors?
Klinefelter syndrome, androgen insensitivity syndrome, and cryptocortism.
Correct. What are the most common classes of testicular tumors in pediatrics?
Testicular tumors can be divided into germ cell tumors, which comprise 95%, and sex cord stromal tumors.
Good. Name the germ cell tumors.
The most common germ cell testicular tumor is a seminoma. Others include embryonal carcinomas, teratomas, yolk sac tumors, choriocarcinomas, and mixed germ cell tumors.
That's correct. What are the characteristics of a seminoma?
Seminomas are malignant tumors that are slow growing and metastasize late. They share characteristics with the female dysgerminoma, including a fried egg appearance on histology. The tumor marker is placental alkaline phosphatase.
Very good. What are clinical features of a seminoma?
The most common initial sign is a unilateral painless mass or swelling in the testicle. Rarely, it can be painful, and there can be fluid buildup in the scrotum, causing a feeling of heaviness.
Correct. How are seminomas diagnosed and treated?
Initial imaging will involve scrotal ultrasound. A limitation is that it cannot differentiate between a benign and a malignant tumor. If imaging in labs confirm a tumor, a radical orchiectomy will be performed where both the testicle and spermatic cord are removed. Biopsy of the testicle is done only after removal to avoid spreading the cancer. These tumors have a good prognosis.
Very good. After orchiectomy, the patient may also receive radiation if the tumor has spread to lymph nodes. Seminomas are highly responsive to radiation. The patient may also receive chemotherapy, such as the bleomycin, etoposide, cisplatin regimen used for dysgerminomas. What are the characteristics of embryonal carcinomas?
Embryonal carcinomas are rapidly growing germ cell tumors that metastasize early. They are usually a part of a mixed germ cell tumor and rarely occur alone. They don't have a tumor marker of their own, but they may take on the tumor marker of other germ cell tumors, such as HCG or alpha fetoprotein.
That's correct. What are the clinical features of embryonal carcinomas?
The most common initial sign is a unilateral mass that may or may not be painful and swelling. There may be signs of metastasis, such as shortness of breath and hemoptysis from metastasis to the lungs or lower back pain.
Correct. How are embryonal carcinomas diagnosed and treated?
Initial imaging will be scrotal ultrasound. If imaging in labs confirm a tumor, radical orchiectomy and biopsy will be performed. CT and MRI may be done to look for metastasis. A retroperitoneal lymph node dissection may be performed if the tumor has metastasized here.
Very good. These tumors are highly responsive to chemotherapy, and the bleomycin, etoposide, cisplatin regimen can be used. What are the characteristics of a yolk sac tumor? also known as endodermal sinus tumors.
Yolk sac tumors are the most common testicular tumors in children under 5. They are malignant tumors that rapidly divide and can metastasize. On gross exam, they appear yellow. On histology, you see Schiller-Duval bodies, which resemble glomeruli. The tumor marker is alpha-fetoprotein.
Correct. Clinical findings are similar to the other malignant tumors discussed. Treatment is with radical orchiectomy and chemotherapy. These tumors have good prognosis with treatment. What are the tumor characteristics and clinical features of testicular teratomas?
These benign tumors contain tissue from all 3 germ cell layers, such as bone, hair, or teeth. They have very low malignant potential, and there are no associated tumor markers. They most commonly present as a painless mass that is firm and often irregularly shaped. A feeling of heaviness in the scrotum may be present.
Very good. Like the other tumors discussed, they're treated surgically with orchiectomy. Let's discuss sex cord stromal tumors of the testes. What are the characteristics of Leydig cell tumors, and what are the clinical features?
Leydig cell tumors are benign and most commonly occur in children from 5 to 10 years old. These tumors derive from Leydig cells and produce testosterone. On gross exam, they have a golden brown color. Histological exam shows Ranke crystals. There are no associated tumor markers. Children with Leydig cell tumors can develop precocious puberty.
That's correct. Let's discuss extragonadal germ cell tumors. We discussed a pinealoma with pediatric brain tumors in the previous lecture. What is the most common extragonadal germ cell tumor, and what are the clinical features?
Sacrococcygeal teratoma is the most common tumor found in newborns. It develops in utero from germ cells at the base of the spine, sacrum and coccyx. They are often detected during prenatal ultrasounds, revealing a mass near the coccyx or in the abdomen. Symptoms include lower back pain, GI symptoms such as constipation or abdominal pain from organ compression, and urinary symptoms such as an overflow incontinence from bladder compression.
Very good. Thank you for joining us for the second of our 2 lectures on pediatric oncology. We hope you learned a lot. Additional notes on this topic will be available at lectureboss.com or by following the link in the video. Take care.